Hey everybody, today we're going to take a look at some cosmetic procedures that can be done to enhance your patient's smile. It's sometimes possible to make some pretty dramatic changes with very minimal effort. There are some concepts that you must understand though as you evaluate a patient's smile, and we're going to talk about those in this chapter. Your book lists 6 concepts to consider when talking with your patient about their smile and then designing a plan to help them achieve their aesthetic goals. And we're going to talk about each of these. But first, when talking about aesthetics and perfect smiles, I think it's important to realize that not everyone has the same goals for their smile that you might have. Most people are perfectly happy with their smiles and might be offended by a suggestion to make changes. If you ask, is there anything you'd like to change about your smile? I think that's a fair question. And if you think there's something to improve, it's a way to ask the question to get an answer that is not going to offend somebody. So I think it's a good question to ask at every new patient exam, because there might be something that's always nagged them that no one's ever really asked them, about before. So I think this is an interesting example that, Kate Middleton's orthodontist didn't really attempt to make everything perfect. And now this is a younger picture here, and this is later on, a more recent picture, and I think it's interesting because I do think some things have been done, either that or maybe just the stress of life and marrying a prince and having children has caused her to wear down specifically 8 and 9, because here I think you can tell they're a bit longer and here they're definitely shorter. Now I do think it makes me think she had something done, because these lower anteriors don't look perfect in this picture, but they do here. It's kind of fun to analyze these things. And then here's another picture. Again, 8 and 9 are a bit shorter. It just kind of softens things a little bit, and you can see that her lower anteriors are nicely in line. I don't know, maybe she did some Invisalign. So the first concept that we're going to talk about is tooth shape. There are varying shapes of teeth, and we usually use these anatomic forms to choose teeth specifically for denture setups. And you'll talk about this more in your removable course. But the goal when evaluating tooth form is to get a really natural form. And you have to have a good understanding of dental anatomy in order to make a good evaluation and understand how to alter the form if necessary to achieve your goals. When considering your dental anatomy in relation to tooth form, it's helpful to understand how the adult teeth look at different stages of life. Due to wear and tear, the teeth will change over the years. A youthful smile will have round incisal angles, which open into incisal embrasures. The facial line angles will be softened. You might even see some mamelons, or at least evidence of mamelons. An older smile will show wear that comes with aging. As the incisal edges are worn down, the tooth will shorten and the incisal embrasures will disappear, or they'll kind of close up on you. The incisal angles will be sharper and more prominent, and overall the teeth will appear more angular. Cosmetic contouring involves minor changes to existing contours. As you can see here, a pretty dramatic change was achieved with very little effort. All they did was round out these incisal angles, probably using like a 7901 or a Christmas tree diamond, and they opened up those embrasures. And it looks like she has a whole new smile. No anesthesia is needed to do something like this. Use that flame diamond, or you could do a flame carbide, a little bit of polishing afterwards, and that's all you need to accomplish this change. Sometimes you have to go beyond a simple contouring to make the necessary changes. These are porcelain veneers. When you do 4, 6, or 8 veneers in the anterior, you can produce a pretty dramatic change because of the control that you now have over tooth form, and in this case, even spacing. I imagine a bit of orthodontics was involved in this case, but even with a missing tooth and a shifted dentition, you can see how veneers turned this smile completely around. You can see that a canine here was turned into a lateral, and the midline was completely shifted, and so what was an asymmetrical, kind of discolored and worn looking smile is now everything you would expect in what we tend to think of as a perfect smile. But this was a big case. It probably required models and interdisciplinary planning, occlusal evaluation, and probably a diagnostic wax-up to show the patient what could really be done. A big veneer case can produce drastic change and may require a lot of planning, but a single tooth case can also be very challenging. It can require greater artistic ability to produce a restoration that will blend in with the rest of the dentition. So in this case, success is really how well the tooth that's being treated matches the surrounding natural teeth. In these types of cases, the contralateral tooth should be examined closely for subtle characterizing features. You can look at the developmental depressions, the embrasure form, prominences, or in this specific case, you can see there's some white spots of fluorosis. This is a case that I did as a D4, and the first crown that we got back from the lab was just a shade that we picked that we thought matched really well, divided up with the 2/3 and 1/3 of the tooth. And the problem was when we got it back, since it didn't have those fluorosis markings on it, it looked awful because it was really just a couple of single colors that were on the crown. So just taking a little photograph like this, which was sent to the lab, it gave them a true picture of the characterizations that were on this tooth, and you can see on the right that the second restoration really blends right in with everyone else. I wish I'd taken a picture of the first one because it really was pretty blah, but this looks like he fits right in just fine. And in this situation, what we were looking for was realism. We wanted this to look like it was the tooth that belonged there. While a tooth may have definite measurable proportions, we can alter certain dimensions of the anatomy to create illusions of altered shape. There's facial width and height, but there's also a third dimension of depth, which is your view in the mirror from the incisal edge, and it's crucial in creating these illusions. Changing these depressions and contours can control how light reflects, and it tricks the eye to see the shape of the tooth differently. To change the apparent width, you can alter the vertical components of the tooth, namely the line angles and the developmental depressions. So bringing the line angles closer together will narrow the tooth. Pushing the line angles out to the edge of the tooth will make it appear wider. This can also be accomplished by changing the position of the developmental depressions in a similar fashion. These are the things you might have to do in dental anatomy to get your maxillary incisor wax up to look just right, but you can understand how these same concepts are necessary when you're restoring or altering the anterior teeth on your patient. To alter the appearance of length, you can change the horizontal elements of the tooth. So by moving the cervical height of contour incisally or gingivally, the tooth will appear shorter or longer. When you're working in the aesthetic zone, it's just a reminder that this is the view that gives you just a lot of information about what is symmetrical and what is not, wherever you're working. So you can't forget this incisal view. It really lets you see almost anything. You can compare these embrasures here You can compare how symmetrical your lingual areas are, and if areas are too closed up or too open. It just gives you a whole lot of information. When you do something like close a space or a diastema between teeth, you are physically going to make the tooth wider. And you can use calipers to measure how much that you need to add to each tooth to maintain symmetry. So instead of leaving the tooth with a wide appearance, though, you can change the position of the line angles to make them appear more narrow. So this is a situation where diastema is closed, and there's no way around it. You physically, laws of nature, have to add composite and make the tooth wider. But you can figure out, how wide is the diastema, divide that by 2, and add that much to each tooth to even things out. But then you can come back and you can kind of tweak those vertical aspects of the tooth to make it appear like it's the same width as it was before you got started. Here's another example of a diastema closure. And what I really like about this picture is how the light reflects off the line angles and the developmental depressions on the facial surfaces in these pictures. These are the light reflections that are really good to look for as you evaluate aesthetics in the anterior teeth. Sometimes you got to move the light around, sometimes you need to position yourself differently, or maybe position your mirror differently. But these give you lots of information about the contours of the tooth and whether or not they're symmetrical. And one thing you'll start seeing in aesthetic photos is this little black space here that we refer to as the black triangle. In a healthy tooth relationship with the periodontium, you won't have a black triangle. So when we start to do some of these procedures to alter things, a goal is to close the black triangle up, but it's not always possible. I think this is another good picture of light reflecting off of the line angles on the anterior teeth. You can see these developmental depressions, you can see the heights of contour coming all the way back. I think it's important to start paying attention to the emergence profile of the teeth. This is the way that the tooth comes out of the gingiva all the way up to the contact area. And it has a distinct shape that's different on the mesial side and the distal side. If you look at these incisal edges closely, you can see slight evidence, just a little bit, that there were mamelons here along the edge. So this is a very youthful smile. You've got the rounded incisal angles and the prominent incisal embrasures, and everything is symmetrical and has pleasing proportions, and we're going to talk about those things next. So as you make changes to a tooth, you have to remember to keep symmetry and proportionality in mind. Any appearance of imbalance will disrupt the harmony of the smile and stand out. Like I said before, it's useful to use calipers when you're changing the mesial distal dimension of a tooth to compare with the other tooth on the opposite side of the arch. But the key is always to have mirror images of the other teeth, especially in the anterior portion of the arch. Then we're going to talk about golden proportion. The golden proportion was first posited by Euclid, who used geometry to describe why elements in art and nature were pleasing and beautiful. The actual number defined by the golden proportion is 1.618. In mathematics, two quantities are in the golden ratio if their ratio is the same as the ratio of their sum to the larger of the two quantities. An object that measures 4 by 6, like a 4 by 6 photo, is very close to the golden proportion. So 4 divided by 6 is 0.67, and 6 divided by 10 is 0.60. When you apply this to a smile, the rule of golden proportion says that as you move tooth by tooth distally in the arch, when you view it straight on from the front, like you're looking at a photo, each tooth will appear about 60% smaller than the tooth in front of it. So this is a nice example of how these teeth, even though we're not looking straight onto the tooth, we're looking straight on from the front, and they appear to get just a little bit smaller as they kind of disappear around the arch. And again, here you can see these lines are drawn here at the end of the tooth, but when they're drawn straight out towards you, you can see that each little section is getting a little bit smaller. The golden ratio has been studied in the arts, it's been studied in the human body, in nature, and from what I understand, it's been studied in the stock market, although I don't think that one held up too well. Since the golden proportion is really about pleasing aesthetics, the more subjective side to this ratio kind of allows for some wiggle room. There was a survey that was done of dentists that showed that their perception of a proper proportion was a little bit closer to 70%, and it can even get as high as 80%. So you've got a really wide range of what people think proper proportions are for anteriors, and it just kind of tells you that beauty is in the eye of the beholder. This is an interesting case that revolves around proportions. This is a teenager who had excessive gingival display due to altered passive eruption, or also called hidden teeth. The patient had fluorosis discoloration and appears to have some type of veneer that was done when they were younger, possibly a composite strip crown is my guess. In this condition, the teeth had a 1-to-1 ratio. You can see exactly how square they are. In picture D over here, you can see that the patient has had surgical crown lengthening. And so the gum tissue was removed to reveal more of the tooth that was hidden under the gums. These old restorations were then removed, and you can see here that some final porcelain veneers have been placed in a 0.8 ratio, but it looks really nice. And in this case, creating proper tooth ratios required some interdisciplinary planning with a periodontist. And this last picture here is just a 7-year follow-up, so you can see that everything is being maintained really well. But that's a drastic improvement just by changing the ratios. But in this situation, the only way to change the ratios was to use a periodontist to solve their gummy smile problem. So the next thing that we're going to talk about is position and alignment. So when the eye is looking for these pleasing proportions of teeth, malposed or rotated teeth will disrupt our view of the arch form. In these situations, orthodontics should always be considered, but there are sometimes some less time-consuming procedures that can be done using composite or indirect restorations if a patient is opposed to ortho. In a situation like a minor rotation, you can reduce enamel in the prominent area and add composite in a deficient area. So this graphic shows how you could use composite and contouring to change the rotation of one lateral incisor and the malposition of the other lateral. Based on the arch form, the more mesial portion of the tooth is reduced here, and the more distal is augmented with composite. That's that little gray bit that's been added. On the other lateral, the entire facial form is augmented to bring it up into that arch form. Could this simple rotation and malposition also be corrected with orthodontics and not have to alter the teeth? Yes, and it seems like something like this would be a really straightforward Invisalign case, but not everybody is willing to put the money forward or the time that's involved to do a case like that. The surface texture of the teeth is another thing to consider, and it's really difficult to reproduce. There are many little characterizations that can alter the way that the light is reflected on the tooth. But it's an important thing to try to match, especially to the nearest tooth or the contralateral unrestored surface as much as possible. Color can also be a difficult aspect to match. We've already talked about the three elements of color, which are hue, value, and chroma. Value is the most important element of color and what your eyes are most sensitive to. And you can even rearrange your shade guide to be based on value to help you make a more quick choice for your color selection. Keep in mind that teeth are naturally several different shades, and it's okay to break the tooth down into thirds or fourths to make it more accurate. Canines are typically darker, especially at the cervical third. You need to pay attention to age, as younger teeth tend to be whiter, and older teeth can be yellow and kind of have a grayness to them. Keep in mind that complexion, makeup, lipstick especially, and clothing can all affect how your eye interprets the shade. Shade guides can be inaccurate due to age. They can change color when you disinfect them. So the most surefire way to know is to place and cure a bit of composite on the tooth before starting the procedure. You need to use natural lighting. The blue bib gives you a place to rest your eyes. So especially if a patient has colorful clothing, you can use that to cover it up. And some people really are just kind of better at seeing shades than others, so it makes sense to involve the dentist, the assistant, and the patient to a certain extent when choosing the color. And this is a video that we've already watched, but you're welcome to watch it again. Natural translucency is the way light can penetrate the tooth, and it's what gives the tooth realistic aesthetic vitality. Opacers can compromise this aesthetic vitality, but are sometimes needed to mask an undesirable color, such as like a metal if you're doing a PFM, or maybe the patient has a really stained stump, which is what we call the prep underneath the crown. Including a stump shade, or the actual color of the prep, is helpful for a lab technician when you're doing porcelain restorations. We're now going to discuss some clinical situations that involve the concepts that we've talked about so far. Keep in mind that function and aesthetics often work together. Occasionally there are compromises, but in the end, function is the most important factor. Occlusion must always be assessed, and anterior guidance needs to be maintained. So consideration of gingival health is also important. You don't want pretty teeth and swollen gums. And the goal is to conserve as much sound tooth structure as possible. Cosmetic contouring is a very simple and gratifying way to alter a smile with immediate results. I most often use this technique when blending in a very small incisal fracture that would not retain a composite well. In this picture, you can see that the size of the chip is such that I would counsel the patient about the downsides of maintaining a small composite like that versus just polishing out the chip. In this case, however, maybe she wants her diastema closed, so I would certainly ask about that before making a decision. To adjust this chip, I would focus on flattening out the distal portion behind the chip, and then I would evaluate it. And many times, there's an area that you need to smooth on the facial surface that will make a big difference. And then the midline incisal angle here will have to be addressed, but I would only do that after treating the other areas and evaluating first. The patient needs to be involved in the decision to alter the front teeth before, during, and after the procedure. They must want to have the changes made and understand all that's involved. I prefer making conservative changes and then allowing for feedback from the patient by looking in the mirror during the procedure, because we can always take off more, but it just gets complicated if you try to put it back on. Here you can see how rounding out these incisal edges gave a more youthful and pleasing look. In this situation, and I've never tried this before, but they used an edible marker to kind of show the patient beforehand what it would look like by darkening out those sharp corners, and they could evaluate things and say, yeah, I think that does look nice. And then they use diamonds and polishers to achieve the look. And this is another little kind of chipped, worn area on 8 and 9. And they have some wear, they have some chipping, and this, since both of them are affected, it really makes it easier to match them. When you're doing a single tooth, it's always harder to blend it, but they did a really nice job of smoothing things out. They were able to maintain this really nice curve on the distal, but you can see here how they opened up this really nice little incisal embrasure right in the middle, and it looks really good. These anterior teeth are flattened due to attrition, but again, opening up these little incisal embrasures, and then, you know, hopefully they'll come and replace these these little class 3s that are stained. If that's the patient's desire, you can get a really nice look. This one may seem a little strange, but laterals are the most commonly missing tooth, and sometimes this is the most optimal treatment plan. Here, they've turned the canines into laterals using cosmetic contouring. They probably used a little bit of ortho to close up some of these spaces, but the look of a canine back here is really achieved using the premolars, but it makes everything kind of blend and fit into place. I think this works well in older patients, you know, maybe they're in their 30s or 40s, not like crazy old, but it's just going to be a lot harder to get spaces that you need to place implants for a missing tooth. So making everything blend like this is a great way to achieve that look. For this diastema closure, the interdental space and size of the central incisors was measured using calipers like we talked about. And the teeth were isolated with cotton rolls, and retraction cord was placed down in the gingival, and they used diamond instruments to roughen the surface of the enamel just to help things stick a little bit better. The etched enamel surface here is indicated by the arrow, so you can see how it's got that frosty look to it. So now they've applied the composite, and they're using a matrix strip to kind of aid in the creation of that emergence profile. And this might also be a good opportunity to use Teflon tape. But they do one restoration first, and it's contoured with a finishing strip, and then the second tooth is restored. And you can see them contouring with a flame-shaped carbide. Again, here they're using a finishing strip and polishers. They're even using a little bit of polishing paste. And then finally they can floss it, and you can see how the diastema has been closed. If you want a reminder of what that looked like, you can see the space here. I think that's a really nice result. Diastema closure can be really difficult. I know these slides make it look just a little easy step-by-step thing, but getting it done right without making the tooth look too wide is a challenging thing to do. Here's another diastema closure. You can see how tricky it might be to preserve this papilla well and not impinge on it while still creating a contact area in the midline. You can see how the lateral's mesial surface was extended just a bit. See how narrow this one is? And they've brought it out to help close that contact area. But they really didn't close it completely. You can still see a little bit of black through that area. The mesial distal width can only be changed so much, and sometimes ortho is the only way to achieve full closure, and we'll take a look at that here in this next slide. So just an example of how ortho can be used to aid in closing. Here's the before and the after. You can see they've replaced these class 3 composites, and that looks really nice. But this one's a pretty serious case. So in this situation, there are obviously some other things going on. It looks like they have a bit of an open bite in this area as well. So ortho is a good way to go to get these teeth back into a more aligned position. Doesn't this look nice compared to how slanted and canted her occlusal plane looks there? And so you can see that now everything is not perfectly pulled together, but it's placed in such a way that the restorative dentist will be able to come in and place composites or veneers or something like that in a reasonable way that the teeth will look very natural. We're going to spend a little bit of time talking about treating discolored teeth. There's different ways you can approach discolored teeth, and they can be treated in very conservative ways that maintain the enamel all the way to extreme cases where you're going to place porcelain crowns to completely replace the enamel. Extrinsic stains are the easiest to remove as they're on the outer surfaces of the teeth, where intrinsic stains are internal and more difficult to remove. An interesting point about extrinsic stains is that they're divided into pediatric and adult types of stains. While some of the etiologies of extrinsic stains are common, there are a few that are different, like gingival bleeding and chromogenic microorganisms in kiddos. So the iron from gingival bleeding, especially from teeth erupting or from poor hygiene, you get this blood plus hydrogen sulfide, and the hydrogen sulfide is a byproduct of chromogenic bacteria. And when those two things mix, you'll get a stain that is black. And it's fairly common to see these things in kids' teeth. I think a lot of general dentists see this and they don't really know what it is, or they think it's some kind of food staining. But it's common to see this in kids, but it's really difficult to manage. A lot of times, as soon as it's gone, it'll come back. I've heard several pediatric dentists say things like, I just tell the kids, I tell mom, come in the day before picture day and I'll clean it all off just so that they can have a nice looking smile for special events, because it typically comes back. This is another case of chromogenic bacteria. You can see these little stains in areas that are a little bit harder to clean where those bacteria are going to hang out. Typically orange and green colors tend to be a reflection of poor hygiene, and brown and yellow are more likely to be from antibiotics, and those black stains are going to be from bleeding. The treatments for extrinsic stains are pretty simple. If the stains are tough enough that they can't be removed by a prophy, you can try some microabrasion. And if that doesn't work, you can use a polishing burr like a 7901 to gently remove the stains. I call it my magic eraser. Occasionally, you might have to resort to bleaching for more advanced stains, but this is typically reserved for adults. Now, if this doesn't make you want to pick up a Cavitron, I don't know what will. This is a great example of the need of a prophy to remove these types of stains. In these types of situations, I think it's a really great idea to give your patient a mirror after cleaning half of these teeth. And they can see, they can look in, if you hold your mirror right, they can look in your mirror and they can see the difference. And it's usually a pretty dramatic response. I think it's a really meaningful thing to do when you're doing a pretty heavy scaling and root planing, because you're probably just going to do one side and bring them back for the other side anyway, and they can see how great it looks and how good it feels to have those stains and plaque buildup removed. This is a situation where I think I'd take my magic eraser to these old restorations, and I do this for several reasons. Sometimes I like to clean up the stains in areas where there's flash just to make sure that the restorations don't need to be replaced because they have marginal leakage. So let's say this patient has no interest in altering the diastema. All they really want are healthy teeth and nice restorations. I would do this little cleanup at no cost. It would probably drastically improve their smile, and it would help them to avoid having to replace all these restorations that maybe really don't need to be replaced. And patients are really grateful for these types of things. It's a great way to earn a patient for life, and it's a great way to get word of mouth referrals. Occasionally when I do this though, and I tell the patient beforehand, I realize that there really is decay on a margin. But if you've gone through all this trouble, at this point, the patient knows that I've done my due diligence in diagnosing the decay, and I've tried everything that I can to avoid replacing them. When we talk about intrinsic stains, we immediately need to classify the situation as vital or non-vital. Non-vital teeth that are stained will most likely be treating with internal bleaching or coronal coverage. Vital intrinsic stains could be hereditary. They could be from tetracycline or fluorosis. They could be from a high fever or maybe even trauma. Here, these blue-gray stains are from tetracycline, and these are harder to cover when you're trying to alter them than something that's yellow or orange like this one over here. So this is due from taking tetracycline. On the right you can see the little bit of yellow staining here on this maxillary left central incisor, which is from tooth trauma, and then the degeneration of the pulp following that. This is an example of fluorosis. This is caused from too much fluoride in the drinking water or some other source in the teeth when the patient is young and the teeth are forming. Too much toothpaste with fluoride, too much swishing with fluoride, whatever it is, they had too much of it. So you usually see this on all the teeth. If it's more localized, the hypoplastic defects might be more from a fever or for trauma. If it's localized hypocalcification, like a little bitty spot of it, it may just be from poor hygiene in that area, especially during ortho, or it could be a defect or a failure of the enamel to calcify properly. Other discolorations you might see are white spots in the enamel that can be remineralized. If they're square, they're probably from ortho. But discoloration might just be from caries. It could be secondary caries. It could be marginal leakage. It could be sometimes from a metallic restoration that just leaves some staining around the edges. Another example of some discoloration could be from a corroded pin holding in a restoration, especially if it's under a composite. It can cause a gray-looking stain. Non-vital teeth will stain from the degenerative products of the pulp tissue. They can also undergo calcific metamorphosis, which can lead to that yellow look like we saw before. So these first two pictures, again, show scenarios where you might try to clean things up a bit before deciding to remove existing restorations and restore, although I think the second case looks worse and more likely to need treatment. This last picture shows the darkening of a tooth with a non-vital pulp. So you can see the difference between this kind of brown or bluish grayish look compared to that yellow tooth that we saw before. Now the walking bleach technique can be done inside the tooth in internal bleaching, and you do it with sodium perborate, but Endo will go more into this procedure in the spring, and they'll also talk about the likelihood of getting good results. So with any cosmetic treatment, there's a series of questions that you need to be asking yourself, and you can ask your patient too, as you make decisions together about proceeding. Some patients have really specific concerns about the aesthetics of their teeth, while others are just interested in their health. sometimes the two overlap. And sometimes a patient's expectations are impossible to meet, while others will have really low expectations, and you can make them really happy with very little. It's your job to have these conversations and determine where your patient is with their cosmetic concerns, and then decide if you or maybe a specialist would even be able to make them happy. So we're going to walk through a little case here. This patient's chief complaint is they have teeth with brown stains and white stains. This is a female who is 20 years old, and here you can see the initial appearance with the high fluorosis, and brownish stains on the anterior teeth were causing her to be embarrassed, and that was what brought her to the office. And I give you a little sneak peek of the final outcome, which is pretty amazing. But this is a microabrasion case. You can see the link here where I found it, but I wanted to walk you through it because I think it's pretty impressive, although it's very time consuming. And I'll see posts come up in my dental groups on Facebook sometimes where they're wanting to use icon or microabrasion to help out patients. A lot of times they're ones who've gone through ortho and have some staining, and it's a lots of appointments coming back, step by step, trying to get these patients to a place where they can blend these discolorations and make them happy. So I think this is a good example of how extensive and involved these cases can be. Let's skip to this. So first things first, you're going to do a prophy and scaling if needed, and take a shade of where you're starting. This is some take-home bleaching trays that the patient was given, and they did this for 4 hours daily. And the goal was really just to kind of smooth out the stains, kind of whiten where they could, and essentially by decreasing the difference between the color of the stains and the color of the teeth, you don't have to do as much microabrasion. So before they started with that, they spent some time whitening. This was done for a week just to get rid of these stains and kind of increase the overall value of the tooth color. Here you can see the rubber dam was placed, and the microabrasion was divided in 2 sessions. The first session consisted of 10 applications on each upper arch, and then the second session was for the lower arch. And you can see that this enamel tends to have a lower hardness than healthy enamel. So you have to be really careful when you go through the microabrasion process. So the pumice is placed here, and you can see that a rubber cup is being used to perform the microabrasion. You can already see some of the pretty impressive changes that are taking place just with this initial polishing procedure. So a desensitizing agent is used just to help give the patient some comfort during the process. It makes the whole process more comfortable. It contains potassium nitrate, which is going to interfere with the depolarization of nerve fibers, and it'll help reduce the painful stimuli of sensitivity. This particular one that they used also contains fluoride, so we've got a nice remineralizing agent in there to also help with sensitivity and help protect those teeth. Just to note, they did this also before they were given whitening trays. Whitening trays can cause a lot of sensitivity, and so this patient's going through a pretty traumatic procedure of removing a surface layer of enamel on these teeth, so it's important to keep them comfortable. So when the first microabrasion step was completed, again, the take-home whitening trays were used, the same concentration for the same time. In this situation, you can see they've come in here with these Softflex discs to kind of round out, remove some of that whitish staining in the proximal contours and cervical areas. You always start with a more abrasive disc, which you know, and move on to the less abrasive discs as you polish those areas. Whitening was resumed for another 2 weeks. And then the patient comes back for polishing and another application of fluoride, which is going to complete the treatment. Here you can see the topical foam fluoride was used for this patient. So pretty dramatic results. I think it's pretty obvious that these front teeth had a whole lot more going on than everybody else. But they got a really nice result from this type of procedure. So this is something that I've personally never done. I think it would be a good continuing education course to take if you find you're dealing with maybe a high population of teenagers getting ortho and then they have some problems afterwards. Or maybe you're practicing in an area with high mineral contents in the well water and you find that patients are wanting to solve some of their discoloration problems.